Yeah, my name's Ian Nixon. I'm one of the ENT surgeons in Edinburgh with an interest in head and neck cancer.
My name's Sarah Stephen. I'm a speech and language therapist based at Newcastle Hospital. And I started my transoral robotic experience when Vin brought it to the UK in 2013.
Laura?
My name's Laura Warner. I'm a consultant head and neck surgeon in Newcastle as well. I have a special interest in transoral robotic surgery.
And Vincent, you're online.
Yes.
Introduce yourself, please. To the...
Yes, I'm Vincent van der Poorten. I'm a head and neck surgeon in Leuven. You can see the hospital right behind me in Belgium. Also with an interest in transoral laser and robotic surgery. Thanks for having me.
Thanks, Vincent. That's very kind. Jay, we've also got 10 minutes. So I'm going to recoup that 10 minutes later. We have a very carefully planned panel. Thank you for your kind understanding. Wonderful. So the way it's going to work, ladies and gentlemen, I'll spend 15 minutes setting the scene for you with the case, and then I hand over to Vincent for the second case, and then I'll come back to the third case, and move on back to Vincent for the last case. And of course, we will pick our expert panel's brain as we go along. I have a COI. I do proctor for Intuitive, and when it's on annual leave and spare time, I bill for those services, and quite handsomely too. So just to kick off, let's have a show of hands. I understand it's quite difficult to do it online, but feel free to inundate the system with messages. Is it a yes or no answer to this question? What do you all think? Do all cancer units, should they offer salvage surgery? Yay? How many yays? Okay, that's very good. And how many nays? Okay, online, is there a feeling online? Who's tapping the stuff online?
Not much.
AJ said yes. Is that a yes or a no, Ajay?
That's a yes. Sorry.
It's a yes.
Yeah.
Okay. So I broadly agree with that. I think with the appropriate implementation of an evidence-based practice, I believe all cancer units should offer salvage surgery, because as long as you have the required facilities for support and for intervention, which are based on experience and robust evidence base, I see no good reason why they should be limited to certain specific units. I've got two other questions, which I won't answer now, but I want your views on it. Here's the first one. Is that true or false? What does the audience think about this? Okay, true. Okay, so true. We have some truths here. We have truths, yeah. And do we have any false? Yeah. Megan, I'm the chair. Survival benefit. We're not talking about functional benefit here. Survival benefit. Yeah. So that's a yes from across the board. Any falses? No. Oh, Shahid, you think it doesn't salvage glossectomy, salvage glossolaryngectomy doesn't offer oncological benefit? What does the other expert oncologist in the audience feel about this?
I think if you consider that, 50% of patients fail first treatment, and you give somebody with a recurrent glossectomy, and if you ask patients, if they have patients for what's most important for them, is it survival, is it function? I think I would really be critical about this, taking like a patient, the tongue out, having the consequence of not able to speak, having fistula and all that goes with it in the era of immunotherapy, etc. So I would be really hesitant ethically to do a glossectomy, but I'm not a surgeon, but still, if it would be my, friend or whatever, I would not do that. I think this day and age, I would not.
But just to put that in perspective, Silke, that's a personal opinion as opposed to something driven by patients and ethicists and so on.
But I think there are alternatives.
Point taken. That's really good to get a controversy going. And the last question before we move into the panel per se. Is that a true or a false? The question is, if you expect the resection margin to be less than 5 millimeter, based on scan an assessment clinically should you not undertake a salvage resection? Okay, right. So we have some idea of where we're going. So let's take, this is not a panel, but it's not a case per se, but have a read of this guy. So this guy is fit. He comes to us with a supraglottic laryngeal cancer in 2019. He completes his radiation therapy. He does well, but a routine post-treatment PET scan picks up a liver met, and he undergoes resection for the liver met. He does that, followed by a pembro chemo combo for a while. And then he develops a local recurrence of the supraglottis and oropharynx. He undergoes a total laryngectomy, partial glossectomy, oropharyngectomy, a free flap. And again, a few months later, I think we are 7-8 months down the line, he's NAD on PET-CT. The point I'm trying to drive at here, Vasav, feel free to come back on this point. We aren't seeing patients behave the way they did when I trained in head and neck cancer. When we had a liver met in those days, that was a death knell for those patients. 3 months was the usual time they lived for. After that, it was usually best supportive care. But we need to open our minds, think outside the envelope, and think about offering patients with recurrent cancer, with patients with distant oligometastatic disease. We need to consider offering them therapy with intent to cure. It may sound controversial, but if you look at the data very carefully, that is simply not the case. So Russell here is just a point to illustrate the fact that just because someone's got a distant met, that patient is not for any further therapy. Is that something we all broadly agree on, audience? We have a really experienced audience here. Yeah, okay. We have lots of head shaking. So that's what Russell's case teaches us. And one more thing, this is a bit of a soapbox for me. When it comes to recurrent cancer, they're not all the same. They're different, especially a cancer arising in a previously radiated field, 5 years, 6 years down the line, is a different cancer compared to the one that was present originally. The difference between residual and recurrent is an arbitrary term, but we need to consider this when we look after these patients. So they're not all the same. They are different cancers. They behave differently, and we need to consider offering patients appropriate treatment. And therefore, we propose that we change the term from recurrent, which is one size fits all, to something that's more appropriate, like a rerunner cancer. These cancers are 3 different types, so we recognize the fact that these aren't one and the same. So when should we offer? What's the evidence base behind us offering salvage surgery? So that's the figure to beat. This is the keynote 048, which is almost the final word on the subject at this point in time, showing that in patients with recurrent metastatic disease, if you offer them appropriate support with immunotherapy, you're getting about a 40% control at 2 years, which then plateaus out. So the figure to beat is about 40%. If we can beat that with salvage surgery, I think that's something we should be offering. If it's equivocal, then it's patient choice and institution choice. If it's not, then we need to perhaps not offer patients any form of salvage therapy from salvage surgery, simply because surgery is invasive and patients go through a lot of hassle recovering from the intervention that we propose. A systematic review has shown that patients after salvage open oropharyngeal resection enjoy something like 50% survival at 5 years. That's overall survival. And that slightly beats the figure from the keynote 048 study. And of course, prospective data from 2 altered fractionation studies have shown that patients who are salvaged with residual disease or recurrent disease, they seem to have a 56% reduced risk of death or progression. So these are the data that come out when you look at the literature for the rationale for offering salvage surgery in the oropharynx setting. And in terms of glossolaryngectomy and total glossectomy, here is the GetTech group showing that it's a small cohort, only 42 patients, but the bottom line is at a median follow-up of 90 months, we still have 1/4 of patients alive and free of disease. So if you scour the literature, you have some support for offering patients salvage surgery. And these are pretty decent sets of data. So on that note, we're going to come to case 1. So that's the story, ladies and gentlemen. So this is a 58-year-old male, performance status 1, he's a retired general practitioner, he's completed concurrent chemoradiation therapy for T3N2C disease. This was a cancer of the tonsil. And I'm not making the chondronecrosis up, it is chondronecrosis. I have no angst against my radiation oncology colleagues. Again, it came from somewhere else. Chondronecrosis, and we found a 12 millimeter tongue-based lesion on assessment, nothing in the neck. Shall I come to you, Ian?
Yeah. What can I tell you? He's going to be likely to be an aspirator based on the fact he's had chemoradiation previously, based on the fact that he's had radiation to the oropharynx, and that he's got the chondronecrosis of the larynx that you mentioned. So he's going to be at significant risk if we are just going to treat his tongue base, which I guess is where we're going with this. Is there a question?
The question is, we've established a diagnosis. So you've sat with him in clinic. He's got a trachea in place because he's got a chondronecrosis. Right. And his GP is saying, I want to live, my priority is survival. What can you do for me?
And the trachea is presumably for a pulmonary toilet or
for chondronecrosis and a compromised airway, the cords aren't moving, and it's a messy larynx.
Well, I think he's a reasonable case to talk about a total laryngectomy to make his stoma easier to look after. He's probably got a completely dysfunctional larynx, whatever you do, and include with the larynx obviously doing a tongue-based resection and a neck on that side, because he's probably going to need a free flap to restore that defect. And combine that with the aim of getting him swallowing, hopefully some diet again, giving him a stable airway and a safe airway. And in some ways, the fact he's got a tracheostomy, I think, makes it almost easier. It would be more difficult if he was going to become a tube dependent, but if he's already tube dependent, I think that makes the decision making more straightforward. And you'd also say that his background probably makes him a good candidate for things like, being independent with stoma care, or perhaps Indeed. Surgical voice restoration down the line.
Great, very thoughtful answer, Ian. But Laura, him being a GP says, don't want a laryngectomy. I'm managing well with my Sylvanegas tube. I have get a voice out. I'm happy with my gastrostomy dependency. I just want this cancer gotten rid of. He's very clear about this. Chondronecrosis, he's on doxycycline, and it exacerbates for a while. It flares up. It goes away again, comes back. He's self-managing that. But it's very clear he does not want to lose his larynx.
So if he is quite clear that despite you're probably going to offer him better swallowing function, but he does not want to lose his natural voice, then considering a localized salvage option, transoral approach would be worthwhile. In these patients, I mean, we would warn anybody who is thinking about this type of surgery that there may be a deterioration in his function, but this guy's already worst case scenario and saying he's happy with that. So assessing the disease becomes the next step, making sure that you can clear it transorally. You're not about to compromise a margin. We're not saying that you're going to try to achieve greater than 5 millimeters margins, but you do need to be able to remove the tumor successfully. And an EUA would be the first step. Detailed imaging, as you have, I assume is there any underlying intrinsic tongue muscle involvement?
No, that's what you see is what you get in there. It's relatively superficial. It's 12 millimeters, and it isn't heading deep into the extrinsic musculature at all.
Excellent. And mouth opening, how's that?
It's good.
Good.
Decent,
okay,
yeah.
So it sounds like this is somebody who may be a candidate for a salvage transoral approach. That may be robotic, it may be transoral laser, depending upon how you feel you can best access it and what your expertise are.
Okay, Vincent, do you want to come back on this?
Yes, I think the both options are very, let's say, defendable, and of course then the patient decides, and if he wants to have a go on trying to preserve his larynx, and there's a good transoral access, you could or use the laser or use the robot, depending on the exposure you get, and then I think just leave it to heal, and probably it will not affect too much his current function, given the fact that it's quite a superficial lesion, I think.
Thanks, Vasant. That's really useful. Okay, so he agrees to this. Is that an assessment? And Sarah, he's been sent to you by the Newcastle team for the green light. You know, as a surgeon,
Post-op.
No, pre-op.
Pre-op.
As you train me well, I would never operate on a patient without a green light from my speech and language dietitian, occupational therapy, and all other AHP and nursing colleagues.
Well done, gold star. Yeah, so hopefully we'd be involved in that MDT discussion pre-op. You know, we'd want to get a real good picture of how this chap's functioning. Obviously, it's been highlighted by Ian there that he's at high risk of having functional problems from his previous treatment and his laryngeal functioning. So we do kind of a multi-panel of pre-treatment swallow assessments. So yeah, as you've put, I'll be doing a VF and a FEES on him. What's his current swallow function like?
So I lied when I said gastrostomy. It's not too bad, despite the chondronecrosis.
So
he's swallowing. He's aspirating. They all aspirate after CRT.
So it's normal swallow. Is that how you describe normal swallow? Okay. So I'll be looking at his aspiration risk and his airway management during the swallow, but also with secretions. I think that would be something post-op that could become problematic for him. So if he's got a dysfunctional larynx, then we'd be worried about aspiration. But if he was to go ahead with the surgery, I'd be also worried about how he's managing that pharyngeal stage of swallow. So in terms of being able to clear the secretions and manage that, which might be problematic. I'd be prepared. Does he have he doesn't have a rig? No. So I would be discussing with the surgeon about feeding, and I would probably say that we would have an NG tube at time of surgery. But I would prepare for him that he's in for a long rehabilitation course, and we would revise that decision at 4 to 6 weeks post-surgery, and he might be somebody who would be needing a long-term gastrostomy. I think it's really important at this pre-treatment stage that you're really making sure that he's making the right decision for him. So you're really making sure that he's aware of what the post-op complications could be from his function. I would also be at that point. So one of the good things about doing the instrumental assessments is that you can really engage them with function. I'll probably be looking at doing some pre-treatment rehabilitation. So trying to improve his airway if we can with a laryngeal closure, supraglottic closure technique, but also maybe doing some pharyngeal contraction work to try and optimize that pre-op.
I'm going to come back to you on that. So before he goes for the surgery, he says, I want a second opinion from an oncologist. So if you see in clinic, Silke, with this being the case, relatively young man, general practitioner, completely clued up, he's saying, I want an opinion before I go for the surgery. Given the current evidence base and current landscape of treatments available for recurrent cancer, what would you advise him in Hamburg?
Well, I would actually go along with you this time, because we know from recurrent cancer, the best option is to do surgery and then check whether he can have any adjuvant radiation. And if he's young and fit, I would probably even combine this with chemotherapy, because you compensate the lack of dose that you actually need with chemotherapy with cisplatin. So the saying is, if you give concurrent chemo-RT, it saves you 10 gray. So you compensate for 10 gray that you're missing. So I would try that, yes. So
green light from right across MDT. Any disagreements across the audience or in the virtual world? JP? Pass the mic, please. Yeah.
It's just a comment on, yes, of course, this is a great case for a laser. But if you look at the scan on the treated side, he's lost all the parapharyngeal fat. So when you cut this out, you may end up with a massive defect and the carotid exposed, because that's the side that was treated. You look at the two sides, there's loss of all the parapharyngeal fat around the great vessels and stuff. So all I'm saying is, would you not consider putting a free flap in or some local reconstruction option? Yes, resect it with TORS, but maybe not leave it to heal by secondary intention.
So I've got his pictures here coming up. So it's actually in the tonsillolingual sulcus. And we went through, got the extrinsic, some of the muscles out, down to the parapharyngeal space. I tend not to put a flap in these ones. The bleeding risk that we have shown in the RECUT study is not significantly higher. We did a separate propensity match analysis for patients who had flap versus no flap, tightly controlling them for stage, age, and everything. the data from margins and complications was not significantly different. N equal to 32 both sides, clearly a smaller number. So I've veered away from flaps. I did put them in earlier, but I've gone away from that. Anyway, that's what we found, ladies and gentlemen. We went in, took it out, and that's the defect down to the parapharynx space and down to the hyoid in there. A clean margin. We always mount it to hell and back, always PowerPoint it, annotate it, goes to pathology, goes into records, and we get everything back. I'm going to come back to this, Sarah, if you don't mind. So it shows that we can do less in the salvage setting and get away with it. Less can truly be more in very selected patients in the salvage setting. That's one point I want to get across here with this particular patient. These patients don't necessarily need trans-cervical, transmandibular, wide local resection with adjuvant therapy. And that data came out of the RECUT study we put together recently. I'll show you the highlights from that. 280 patients, that's your data. At 2 years and at 5 years, your overall survival is 50% or so in the rightly selected patient. Your DFS at 5 years is 43%, DSS 60%, and you can see good data at 2 years. So I think this may be the last word on the subject for a little while to come. So it appears that you can get away with truly doing less in this setting. Vincent, I'll hand over to you in a minute, but I want to get Sarah's take on this particular thing. So Sarah, my point is, it's a post-CRT patient. There's fibrosis, there's shed load of inflammation, whatever's going on. This pharyngeal contraction exercises and so on, how much does that have an influence on outcomes? What's your take on the matter?
We don't know. We've got no data on it. I think that
it improves morale for patients, I know.
Morale?
And for the surgical team as well.
I think it's really difficult. You know, these patients are going through an incredibly stressful and difficult time. You know, even the whole kind of shared decision making around what to do, it completely preoccupies their mind. And so for me, there's no harm in doing it. If it's going to help, one, with muscle function and it potentially improve their post-op recovery, then let's give it a go. But also I think what it does is it really engages them in that rehabilitation mindset from day one, which is what we need for these patients. You can't put someone through salvage surgery if they're not going to engage in rehab post-op. And so for me, part of doing that prehab is about making sure that the patients are going for the right treatment.
Thank you. That was a loaded question, by the way. And the reason I asked is because I've seen a few patients with open salvage and transoral salvage. I've got now patients going 4 or 5 years now, forming a new Passavant's ridge at the posterior pharyngeal wall. That's lower down at the hyoid level. These are new muscles and bands forming with rehab and therapy in the longer term. And that I think helps with the swallow. The Passavant's ridge you see in the primary setting when you take off the soft palate. So apologies for dropping that on you. Do you want to talk us through this particular flowchart of yours? That
yeah, so I did this when I was working when we first started the TORS program, because we really needed to educate the MDT on swallow function. Being polite. Keep it simple. So, you know, we had to really stratify our patients into what level of functional changes we're expecting in the pre-op setting. And it was really important to highlight the, you know, the predictors of a more significant post-op functional problems. So we did a bit of a risk stratification. So anyone who crossed the midline of the pharynx was a higher risk. Anyone who had obviously larger disease resections, but also all of the patient factors. So we know that age and that pre-existing dysphagia. And I think also, you know, in terms of COPD and management of aspiration, which is likely to happen post-op, it's really important that we factor all of that in. So that was to help us all understand who needed what.
Thank you. That's my Bible when I select patients. Vincent, over to you now. I'm happy for you to share the screen and discuss your fascinating second case. Can you hear? Yeah, it's taken over. Wonderful. We can't hear you yet, Vincent, if you are speaking.
Okay, can you see my screen now?
We can see your screen. We can hear you, see you very well.
Okay, good.
Wonderful.
So thank you for inviting me to this North Sea conference for me. And this is the first patient that we had in Leuven. It's a 56-year-old housewife who's a smoker for 40 years. Also some liver damaging substance use. And she presented in September 2017 with a 3 months existing left submandibular swelling in a regional hospital. And they suggested an MRI. And on the MRI, the radiologist suggested that this may be a pleomorphic adenoma of the submandibular gland. So then there in that hospital, she underwent a resection of that submandibular salivary gland with the following results: a paretic marginal mandibular branch. PA showed not a pleomorphic adenoma, but metastatic SCC P16 negative and with positive margin, and 2 more metastatic lymph nodes adjacent with vascular invasion. And then in the same hospital, they did the next day a PET CT because they had done frozen section during the surgery and did not find a primary. And then she was referred to us a couple of, let's say, 10 days later. And when we looked at her, examined her also with narrow band imaging, we did not see any primary for this strangely located level 1 nodes. She still had palatine tonsils and the lingual tonsils there. And so the question to the panel is, what would you do in this situation?
I'll direct this to Ian.
That's very confusing. Is she ironing a skirt? Is that what we're? I didn't catch the rest.
Well, it's just
Ian, there is not a job in Leuven for head and neck cancer surgeons.
Okay, so, sorry. So they took out this submandibular gland, but it's a P16 negative cancer. Okay, so yeah, that's a very unusual situation, and you're already kind of off-piste before you start, which is always difficult to get back on. But there's no obvious primary. So in our institution, we would do a PET scan. You've already done, no primary. We would then do a bilateral tonsillectomy and EUA. We would actually do biopsies of the tongue base. It's not been our practice to do a maltectomy or whatever we're going to call it in the next generation. And we would go looking for the primary, is what we would do next.
Did you get that, Messa?
Yes, I got that. So this is DMR before resection, just showing that not all radiologists are experts in calling this a pleomorphic adenoma. So, well, in fact, this is what she had, P16 negative TXPN2B, or if you use the latest edition, N3B, because positive margins. And so Ian already said that he would go for looking for the primary. What about primary chemoradiation? Is there any proponent for this approach?
Laura?
So you have I'm assuming an excision of a positive neck node, positive margin. So you have extracapsular extension and you haven't done a formal neck dissection. So treatment of this patient's neck is going to involve chemoradiotherapy. The question is that you have to discuss at MDT, is there anything further surgically that you could do that might be able to focus your chemoradiotherapy and avoid panpharyngeal irradiation? Because we know that that has a negative impact upon long-term function. So if the patient's had a tonsillectomy, diagnostic tonsillectomy, you have an option, if they have good access, of doing a tongue-based mucosectomy, again, either with a laser or a robot. If the access is challenging, then it becomes more of a discussion as to whether that's likely to add anything to this patient's care. And I think the HPV status comes into play here as well. For patients who are HPV negative and they've had a negative panendoscopy, the chances of finding a tongue-based primary are less than in the HPV positive population. So a careful discussion about whether or not that adds anything to this patient's treatment. And that's a discussion for the MDT. It's not clear cut, it could go either way, and therefore you could involve the patient in that discussion as well.
Yes, so in our MDT, the discussion was, or indeed immediately chemoradiation, or go for surgery. and also considering doing a proper neck dissection, maybe omitting the chemo if nothing is found in that neck dissection, and then combine that with removal of the tonsils, and both the lingual and the pharyngeal. And in fact, that was what we went for then in 2018. And that's the pathology we got. We got normal lymph nodes, no residual disease in the neck, but also no palatine and lingual tonsil primary. And then we discussed again, should we go for chemoradiation? Should we go for radiotherapy unilaterally, bilaterally, still panpharyngeal, only base of tongue? I don't know what the panel thinks about this next stage, given the negative pathology.
I might get our expert oncologist panel at the front row in. So Silke and Shahid, feel free to pitch in and see what you think about this.
Well, this is the everlasting question. It's taking a shower or a bath, right? So with the unknown primary, most radiation oncologists would not do mucosal sites anymore because there's plenty data, even though it's all more serious, that there's really no benefit treating the whole pharyngeal mucosa or whatever. So I would only treat, first of all, unilaterally, and I would give chemo RT because she's young and she has this extracapsular spread, but I would only treat the lymph nodes. I would not treat the mucosal sites. There's no benefit. And these patients have a 2% per year probability to develop a second primary, so she has to be watched closely. But whether you treat or not the mucosal sites, that won't make any difference.
And does that depend on P16 status or not? This statement.
You can take that, Silke, before we head out to Shahid. So Vincent's question is, does that depend on the P16 status?
No, it does not. Does not depend on P16 status. Not for me, in my opinion.
And for
an
how
audience poll, Vincent, this would be interesting.
Sorry.
How many
Yes.
of you would really perform a tongue-based mastectomy and a tonsillectomy or a montectomy in patients who are P16 negative neck nodal metastasis? Show of hands. So most of the robotic surgeons here would perform Laura, montectomy in that particular instance. Thank you. So Shahid, you performed a systematic review for the UK Consensus Day on the unknown primary, and we came up with some recommendations for radiation therapy in that setting. Would you summarize for us what you found and what your thoughts are?
In a single sentence, involved site only.
Wonderful.
Yeah.
I like that brevity. Surgeons can understand that. Surgeons get that completely. So audience and audience in the virtual world. So in the unknown primary, it looks like the pendulum is swinging away from pan-mucosal radiation to almost involved site only. It's quite a significant shift. And there's one more additional de-escalation strategy in the consensus document. Read that, and I won't say it now. It just confuses things. So that's really good. Thank you, Vincent. Any further questions, Vincent, of the audience? What did you do in your center in Leuven for this patient?
Well, this is 2018, and our MDT advises pan-mucosal radiotherapy, given the fact that it's P16 negative, and so there's still chances that it's not in what we resected. And the MDT also advised to do bilateral neck radiotherapy, but in the regional hospital where she was referred back on her own demand, they only treated the left neck, so unilaterally. But this panel is about recurrent cancer, and
Saga continues.
So she went in follow-up, but then had contralateral pain in the throat June 2019, and then in the regional hospital they found the contralateral right side strange lesion on the lateral pharyngeal wall, so opposite the previous node. So very strange, but in fact, a very strange new lesion. Again, P16 negative squamous cell carcinoma. And this is the MR showing that area. And this is the examination under anesthesia, showing this lesion, quite naughty looking lesion. And the question to the panel is, how should we treat this patient who has had contralateral radiotherapy and a contralateral neck dissection, and of course tonsillectomy and base of tongue resection.
We'll leave it to Ms. Warner to manage this patient.
Lovely. So obviously you need to make sure that there's no distant disease. There's nothing that would prevent you from treating this radically. I assume that's been done. The way the clinical photograph gives the appearance of something coupled with the imaging, something that's relatively superficial, lateral base of tongue and onto the lateral pharyngeal wall. And she's had a tongue-based mucosectomy in the past, I believe, and access was good at that point. Hopefully nothing has changed from that point of view, and this could be something that you could access with a transoral approach with an ipsilateral neck dissection. I think you have to weigh this up very carefully with a discussion with your oncologist to see what they would be able to offer the patient given her previous irradiation to the contralateral neck. Are they confident that they could give this a full dose CRT, or would their radiotherapy fields or dose be restricted because of her previous treatment? But you have to present both sides of that. But I think provided the access hadn't changed, then the transoral approach still seems feasible.
So before I bring Ian in, oncology, the mic's in.
No, Vin, go ahead.
There's a comment from a senior surgeon in the audience.
Hi. Can we just go back to the MRI scan, please? Because I think that we have a mismatch here between the radiological findings and the clinical findings. So I think that clinically, if you go to the clinical picture, that looks relatively localized. But I think on the MRI scan, you see an area of enhancement that's out with what you see on the mucosal surface. So I think that if you are planning a transoral approach for this, then you have to take super wide margins, because otherwise you'll end up with involved margins.
I thought exactly that. That's quite a thick tumor.
Yes.
It's horseshoe shaped, isn't it? It's on the scan, it's almost a 50% circumference of the mucosal surface.
That needs a whacking.
So it's a big resection. This is not an easy TORS case.
No.
So hence we've graduated from the previous 12 millimeter case to this one. So there was one question that Laura asked of the oncology colleagues. So because she's had only one-sided radiation previously from the other hospital, would you consider radiating this tumor and the ipsilateral neck?
She should, yeah, it should be possible.
Should be possible.
Should be possible with the current modern techniques, yeah.
Shahid? Yeah, okay. Certainly possible. So the answer to that, Laura, is possible. So you'd sit down and discuss with the patient and consider that. I'll come to you, Ian, for the approach. Shall we do that, Bessa?
Yes.
Yeah. There's a question from the audience. We'll pick that up in a minute. Ian, approach?
Yeah. Well, to be honest, in our hands, we would. It's kind of an unusual case, isn't it? We would probably ask for an opinion from one of the robotic centers is actually what we'd probably do. But were she to be treated in our center, we would be thinking of a mandibulotomy and a neck dissection and an open resection with free flap reconstruction for that, given our current setup. And overall, I think if we could persuade the oncologist to give radiation, that she would probably do better, get back to housework quicker that way. So, we all want to see that.
So these are decision-making factors in Edinburgh.
That's what we base all our decisions on. Yeah.
Quicker return to work is clearly a very important factor. No? Okay, so we are. Laura, do you want to come back on that approach, or Jim says it's quite an extensive tumor?
I think the mucosal involvement on the scan does look more pronounced than the primary tumor appears to be. I think you would need to consider, even if you're resecting it transorally, whether you needed to do some kind of reconstruction to help with that. But I think if she's going to be offered a full dose of oncological treatment, I think that would be the best option for her.
Okay, we have. Audience, experienced surgeons, any comments, trainees? Asit, let me get you on mic.
I agree with Jay, and I'd be very reticent to take that sort of case on this. She's got that disease. She's clearly still smoking, I assume. I think the basic question, we're sort of getting wrapped up with TORS and is she still smoking? You know, I mean, quite frankly, she's going to continue to smoke through treatment, first time and now second time. That in itself is driving bad disease. So I'd be very reluctant. And if we had our oncological colleagues to facilitate treatment in this regard, I think that's probably her best option, quite frankly. But I also just think the basic thing of, is she smoking? And
she's not smoking anymore. So she quit upon the first treatment.
So to come back on that point, so you said it's bad disease and she's clearly young. Decent performance status, Vasa?
Yes, she's ironing. So no, she's doing well. She's
yeah, she still irons. Yeah, so that's I know for a fact that's heavy duty, you know.
He started this, not me. Yeah.
No, she's in good doing. She's up and about. No problem at all.
I think we need to add ironing in the performance status score and the Karnofsky and the ECOG. I think we should consider that. So if you say it's bad disease, and to my mind, a HPV negative, P16 negative bad disease preferably treated by a combination of surgery plus radiation therapy. So why hand over to your oncology colleagues in this particular instance? She's young, performance status is decent.
What I'm trying to say here is that there's something more than just HPV status. We don't know half as much, 2/3 as much as about, it's not just about HPV with this woman. There's other things, there's other biomarkers that we're not aware of. That's what I'm saying. And I mean, if we're going to try and get a good result with her from a surgical perspective, or my point was that I'd be nervous to tackle her transorally, because I think we're possibly just tip of iceberg with this, but we don't know, do we? But she's recurred quite quickly, having had disease in the past. It's odd, she had a level 1 to begin with, so
it's the opposite side.
Now it's the opposite side. So this whole case to me is just sort of odd, very odd, highly odd. And I would agree with Jim wholeheartedly that if we're going to take on a surgical approach and give a adjuvant treatment thereafter, if we can, then the approach for me, I'd be personally nervous to take that on transorally. And when we're thinking about balancing her function with her putting everything together, if my oncology colleagues felt that she had a curative option, which wasn't going to compromise her, then you've still got surgery, salvage surgery to fall back on should she recur again, which wouldn't terribly surprise me, given the story, the slightly odd story that she had. I mean, it just doesn't add up.
So I'm going to bring Dr. Trainer in. So Megan, so I know you've been paying attention. I've been following you, okay? So this is a woman who's got a new primary in a previously unradiated field on the opposite side. Could you show the clinical picture, please, Vasa? So we have an experience. Yeah. So that's the opposite side to the first unknown primary. She's had maximum therapy, including neck dissection and CRT. This is radiotherapeutically the virgin side, surgically virgin side, recurrence. You're going to tackle that surgically or hand her over to your oncology colleagues in West Virginia to deal with?
So I guess I would want to look at the first primary, and is it how many years after?
T0. You weren't paying attention.
Truly T0. Okay. So, all right. So in this case, one, I'd really want to look at the imaging. I would be concerned that white area.
Please? Wonderful. You weren't paying attention.
Yeah, I remember. So now I see. Yeah. So this thing crossing the midline here, that white area, looking at it, is what's most concerning. That's going to go more than halfway to get a negative margin. And then the other thing is looking at the way these have multiple nests and they're multifocal sometimes. I'd be just concerned that I wouldn't get a negative margin even if I took that whole base of tongue. So entire base of tongue, previous full treatment, concern about the margins because it was an unknown primary and now is big and rolled. Also ulcerative. Ulcerative bothers me because I worry more about
primary oncology versus primary surgery.
I think oncology.
Okay, off to oncology. JP? Great case, Vincent.
Should we?
It looks more extensive than the endoscopic picture. So you could easily be lulled into a thing that I'll just call this out. Yeah, it doesn't look that massive, but just look at the mucosa are all around the tumor. I suspect that you could get positive margins in the resection, which is not great. It doesn't make you feel good. So
Laura, it's you and I against the world, I think. Right. Carry on, Vincent. What happened next? What did you do next?
So we saw this publication by Philip Gorf, who combines, as also Ian suggested, a resection with a free flap, but not an open resection, but following transoral robotic surgery. And so we started off with the right neck dissection. And the nice thing about that is if we go back, coming from the neck, you can then isolate the vessels, put a swab there, and then without any fear for the vessels, do then the transoral robotic surgery resection until you meet your swab that's in the neck. And then, of course, you have a huge defect. And so Philip Gorf published on doing that way and then putting in a free radial forearm flap with the robot. Also, you, Vin, published on that. This is your paper. We did the same thing, but we did not use the robot to sew in the flap. We just did it manually from below and from above.
It's a Marsden and Guy's paper, and we have two Guy's faculty in the audience.
Yeah, so we don't know about the functional long-term outcomes of this quite extensive salvaged surgery, but this patient did quite well. She was decannulated at day 10. She went home with oral feeding with no consistency modification. On day 15 was in fact the way she was feeding. And we did obtain clear margins, but extensive perineal growth and lymphovascular invasion, and also 2 positive nodes. So this is the new situation. What now? Would we go then for chemoradiation or radiotherapy? That's a bit the question to the non-surgical colleagues.
But before we go down that road, that's amazing recovery for that patient with a large resection of free flap. You must have amazing speech therapy colleagues who get the patient.
I want to come and work with you
so rapidly. Sorry, Dr. Stevens, did you want to come back on that? Please.
Amazing. Yeah, to be honest, it was a lateralized tumor, which we know they do a little bit better. Certainly in the acute post-operative period, we'd be really optimizing instrumental assessment at this point. So we'd be using FEES a lot to guide decannulation and oral intake. I guess oral feeding means that they were taking oral intake, but not necessarily off their NG. I would be quite surprised with this case that they were off the NG before they were going home. But and yeah, I mean, I would have prepared this patient for quite extensive rehabilitation post-op, but it sounds like she did very well.
Yes, she did amazingly well. We didn't expect that either. But
the point about, I take a point about the flap for this case, Maso. Of the 80 odd recurrent TORS I've done, I've had 1 30-day mortality, and that is exactly where the tumor was. The lateral pharyngeal wall, and the patient bled on day 19 and had a stroke, not dead yet, off to the rehab home with a stroke, but it's a really bad stroke. So much of the GCS is something like rubbish, like 4 or 5. But you're absolutely right. These patients need a flap when you have a low lateral pharyngeal wall lesion. Okay, back to the question of adjuvant radiation for this particular patient. Yes, Silke is saying yes. Shahid, yes, yeah.
But not to chemo-RT. I would give her radiation therapy like you would do it in a primary setting. There's no indication for a combined treatment.
Yeah. So that's in fact what
this is almost a rerunner like cancer. It's in a radiated field. It's a new primary. Okay, over to you, Maso.
So that's in fact what we did. She went for 60 grays on the right neck and base of tongue, and she remained in further local, regional, and distant control since 2017 until 2020, when she developed a floor of mouth lesion of 5 millimeters with 5 millimeter depth of invasion following laser resection that we did. She had a complete resection. And then a couple of months later, she developed lung mets because of a CPS score of 1, which is considered just the margin to start something in Belgium. She was started on Pembro, and she already showed effect of that in January. So 3 months later, and then it progressed a bit during 2021. No new lesions, so she was kept on Pembro, and then early this year she had a new tumor detected, the T1N1 SCC of the esophagus, and at that point Pembro was switched to cisplatin 5-FU for that new tumor, and in fact partial remission of lung mets after 5 cycles, and I just checked her file. She's now after a 6th cycle of cisplatin 5-FU, and the esophageal primary has disappeared, and the lung mets are in remaining control. So this lady is still going strong for the moment. So that was just this case. Finn, I hand it over to you again.
That was a great case. Again, it underlines the fact that when it's recurrent, you can't give up on them. With current treatments, both surgical and non-surgical, patients do really well from a long-term perspective. And we kept it going for 5 years since the first diagnosis. I know I've got 5 minutes, Jay, correct? 2 minutes, okay. So that's really a good note to finish us off on that. Any questions, audience? Anything you wish to contribute? Trainees especially, we have some really head and neck dedicated high surgical trainees. This is going to be a future. You're going to see lots of patients with recurrent cancers who you need to work up, and they take more time, understandably. They are difficult customers to manage in terms of their needs for treatment and for supportive care. So any questions or comments would be welcome. Of course, Sam. And people like you, Sam, with the laryngology expertise, we need your input for the head and neck long-term management of these patients.
Thank you. I'm Sam. I work with Jay. Happens to be a laryngologist, and obviously in the same club with speech and language therapist. Now, is it becoming a common practice that head and neck cancer surgeon colleagues are asking for preoperative swallow function? Not just for the advanced one, but for everyone. Because, we can offer so much in terms of functions afterwards. And also, if you are successful with your surgery and the patient is left with unable to eat and drink and stuck with a peg for the rest of their life, not able to have a cup of tea, that's not really a good sign of success. So what's your thoughts on that, please?
That's for Sarah, I think. Do you want to pick that up, Sarah? And Ian?
Well, in Edinburgh, we aim to every head and neck cancer patient sees a speech therapist before treatment. They almost all get a full kind of swallowing assessment. There's resource implications. So some of the wide local excisions of the tongue and T1 larynxes don't always, but fundamentally we try and swallow assess everyone in Edinburgh.
Yeah, certainly. I mean, the guidelines are that speech and language therapists are heavily involved in the patient pathway from pre-op all the way through, and not just with advanced cancer. So we know that there are predictive factors such as age, comorbidities, and pre-treatment dysphagia, and that does occur in lower intermediate dysphagia. So some of Kate Hutchinson's TORS data showed that I think it was 4% of patients with low T1, T2 oropharyngeal tumors had pre-treatment moderate to severe dysphagia. And I think some data from Emory has come out as well, and they showed that a quarter of their patients had pre-op dysphagia in that low to intermediate T1, T2 oropharyngeal cancers. So, you know, it's really important that that pre-treatment assessment happens and that you get the speech and language therapy involved.
And I would agree with that entirely. I think all head and neck cancer sites, knowing about their pre-treatment function and knowing what their expectations from treatment are really, really helpful, because they do help to guide our decisions, and they don't always disclose that to us. So most patients tell me they can swallow fine, and they often can't. And a lot of my pathos patients, particularly the tongue-based ones, we've picked up pre-treatment aspiration on their video fluoroscopy pre-op. So it is quite helpful and does frame what their rehabilitation kind of focuses on as well, but also helps you to balance their expectations, particularly when there's a choice of treatments.
And I think in terms of that kind of pre-op, you know, if you're spotting pre-op aspiration or dysfunction, you're preparing the patients, but you are really preparing them for what's coming afterwards as well. And that's really key. I think that in terms of, you know, how function is being highlighted, it's incredible. And the fact that function is heavily involved in a lot of clinical trials that are going on. But I think what's also really important is to, you know, swallowing is complex and it has lots of impact, and it's synonymous with quality of life. And if we just look at one level of swallow, like the patient reported outcomes, we're not getting the information that we need that will guide our clinical practice. So things like the ORATOR trial are great, but, you know, that doesn't change how I prepare or how I manage patients functionally. What we need is that multidimensional panel of swallow outcomes, so that we really, really get an understanding of how patients are coping with the treatments that we're giving them.
I'm going to answer a couple of questions, then the last few thoughts to leave you with. Dr. Awebem asks, if treat involved site only is a new dictum, what happened to the field cancerization theory? I can pick it up. Does the panel want to pick it up before I do? In recurrent cancer, I take your point, Dr. Awebem, about the field cancerization, but we can only treat what we see. If you believed in field cancerization, which was touted, then I'll have to take the entire oropharynx out, entire oropharynx and larynx and hypopharynx out. So we can only take out what we see, and that's what I do. And we get our results from RECUT, especially. You can see that with 80% control at 2 years. And as cancers return, we treat the new ones. The next question from you is, what will be the impact of liver disease in considering these treatment options? I presume if liver disease is there, we manage them in concert with the hepatology colleagues as appropriate, and assess liver disease before considering any chemotherapeutic or immunotherapeutic interventions. Immunotherapy has spawned so many new fields in dermatology and hepatology. So much, it's inflammation galore. On that note, I think we've shown you the true power of multidisciplinary working. We've seen our expert panel, both from the floor and from the podium, really deliver a stomping performance on the management of recurrent cancer. Thank you for your time. And just to plug, BARNO, the British Association of Head and Neck Oncologists, is a sole multidisciplinary organization for head and neck cancer care in the UK. If you're not a member, you're missing out. So sign up and become a member. I sign off as president of BARNO. Thank you for your attention.